Vreeland. I am one of the presenters for our breakout session today, which is related to the Governor's Challenge for Washington State. And we're going to be doing a review of the last 5 years that the Governor's Challenge has been in place here in Washington State, as well as talking about the future for our plans on moving forward, given that we have a new governor this year and recommitted Washington State to the Governor's Challenge to prevent suicide among service members, veterans, and their families. Today we have a few speakers, and then of course we're going to introduce ourselves, and then we also have some panelists that will talk about each of the priority groups that we have. So we have 3 priority groups. We'll go more into detail about that. But I will start with the introductions. As I mentioned, I'm Nicole Vreeland. I'm the Suicide Prevention Program Manager for your Washington State Department of Veterans Affairs. I am new to WDVA, however not new to state service. I have been in state service for about 17.5 years, and by education and discipline, I'm a licensed mental health counselor, nationally certified. Started in community mental health, where I had the opportunity to work with just a different variety of folks of just different age groups across the transition, the lifespan. Got to work with a lot of military members as well as their families. I was a military spouse, and that's how I got here to Washington, originally from Maui. And then also worked for the U.S. Navy as a civilian in Hawaii as well as in Virginia before coming here to Washington. And it is a pleasure to work among all of you in serving the goal and purpose of what we're all here to do, which is to support service members, veterans, and their families. So I will pass the mic on to our other presenter, and then we'll go down the line.
Good afternoon, everybody. It's good to see a lot of familiar faces in the crowd. My name is Pruitt. I'm a psychologist by training. I have the good fortune of working at VA Puget Sound, so that's the Seattle and American Lake VA hospitals, the federal VA side of things. And there I serve as our Director of Suicide Prevention Services. So we'll go into some of these things that you've heard probably 988 mentioned a couple times over the last couple of days. When you call 988, you talk to a crisis responder. When you press 1 to identify as a veteran, they refer you back to your local VA. So that's my team that then picks up and talks to you and works through you, connected to care, resolving that crisis, those sorts of things. I also have an associate professorship at the University of Washington School of Medicine. I know there were some "Go Cougs" chants yesterday. Those will not be tolerated. But I'm just really happy to be here. I've been a part of the Governor's Challenge from the get-go, so we'll be talking about that piece of it. And with that, I'm going to ask our additional members to introduce themselves.
Hi everyone, my name is Elizabeth Emmet, and I am from the Department of Health. I work on the 988 line, and I'm the Community Engagement and Outreach Coordinator. I've been at the Department of Health for 3 years, and I've been on the Governor's Challenge for 2. I originally started in public health and education, and I moved over to mental health. I like to call myself veteran adjacent. I'm married to a Marine, daughter of Air Force, granddaughter of Navy, and I'm going to pass it on.
I'll just start by supporting Dr. Pruitt, go dogs. Yeah, we know where we are, don't worry. My name is Shawn. I am President and CEO of NineLine Veteran Services. I have had the pleasure, similar to Dr. Pruitt, as sitting on this Governor's Challenge since it was first found. I currently sit as the chair for the Washington State Veterans Affairs Advisory Commission. I also am the chair for the Puget Sound Community Veteran Engagement Board, and it's kind of a full circle day for me because I get to present to all of you cool people on a lot of our findings, and to Nicole's point, share our strategic goals moving forward. It is a nervous day for me because I don't typically get to present in front of one of my mentors, but you know, Peter's here, so I can't do anything about that. Other than that, it is a pleasure to be here. Missing anyone? Okay, well then we look forward to presenting to you guys.
Now, we do have other members of the Governor's Challenge in the audience. So if you are or have been at any point a member of the Governor's Challenge team, will you please stand up? Yeah, you stand up here. Great. Round of applause. if you've heard of the Governor's Challenge, if you've seen the Governor's Challenge website, heard somebody talk about it, please stand up. Not necessarily. We're trying to get sort of a capture of who we reach and who we need to reach. Okay, this is helpful, thank you. All right, Mark, you want to go to the next slide? Okay, we're gonna start off with a little video. This is something that's been put together recently for the Governor's Challenge. Just documenting some of the work that's occurred, because there are folks that haven't heard about this, and I think would be good, not only contributors, but just awareness for the veterans that we work with. So we'll start with our video.
What is the Governor's Challenge? Our mission is clear: lower the rates of suicide among service members, veterans, and their families, or SMVF, in our state. However, simply decreasing the numbers isn't enough.
You're showing the wrong
We are
tab.
dedicated to equipping individuals and communities with the necessary tools and resources to help prevent suicide. Government and state agencies, nonprofits, professional organizations, medical and mental health professionals, and tribal members have united to develop and execute the SMVF Suicide Prevention Strategic Plan. We are committed to our mission of reducing suicide rates in our state, backed by a dedicated group of passionate leaders collaborating for the Washington State Governor's Challenge. Team 1 focuses
We'll just do audio.
in screening for suicide risk. Service members, veterans, and families live, work, and thrive within our communities. To reach them where they are, we are creating toolkits and trainings to support community members and organizations to ask the question, did you or your family members serve in the U.S. military? By asking this question in community settings such as healthcare, emergency services, and first responders, we can advocate and educate for culturally informed care, expand touch points for suicide screenings, and increase service clears, lower the service members, veterans, and their families.
Team 2 is focused on promoting connectedness and improving transitions through the peer support group, engaging on the rocks and reaching out to the Navy, Air Force, and Marines. Transitional periods are given in the life of a service member and veteran. Changes in duty station, changes in duty status, and even the transition from military to veterans can introduce major changes in the lives of a service member, veteran, and their family member. Group 2 is working to ease the challenges those transitions put on our military and veteran community and ensure that the necessary supports are in place to give help when it is needed.
Team 3 is focused on increasing lethal means safety and safety planning. Team 3 is committed to enhancing lethal means safety and crisis planning within the service members, veterans, and their families' community. Because firearms are used in over half of all suicides and are even more common in the SMVF community, promoting secure storage of firearms is essential to the cause of suicide prevention. In partnership with our local communities, we are focused on the distribution of firearm and medication storage devices. In addition, we offer crisis safety planning to include education on secure firearm storage and voluntary, temporary transfers of firearms if needed. By creating a buffer between individuals in crisis and access to lethal means, our goal is to prevent hasty decisions that could lead to tragedy. With improved planning and access to resources, our mission is to provide support to our community in order to lower the risks associated with suicide and save lives.
By working together, we are building a more resilient and secure community. We invite you to be a part of this important mission to reduce suicide rates for our service members, veterans, and families in Washington State.
Thanks, Mark. So you heard, for folks that know her name's Heather Sanchez, but right at the beginning, you would have seen her, but you also heard her say that reducing the numbers is not enough. You might be thinking, like, isn't that the whole point? Right? It is. It's a necessary but not sufficient part of what we're doing. And so when we think about the goal of the Governor's Challenge and why we're doing this work and why we've invested 5+ years at this point, is because yes, we want to drive down the numbers, but we're also trying to build a community, right? A community of folks that are, as we heard in the theme of the conference, putting veterans first, focusing on the unique needs of that population, and creating a state environment where they have meaning and purpose, feel valued, and suicide becomes something that's off the table because of all that upstream work that has happened. And so, honestly, every breakout that you've seen, the background music from Music Works for Veterans that's happening, that's all part of this, right? It's all part of giving the veteran community those options to express and connect and find meaning in their lives. And that's what this is really all about. Next slide. And one more. Okay, so about 10 years ago, SAMHSA, the Substance Abuse and Mental Health Services Administration, and the federal VA central office back in DC, as well as the CDC, got together and said, okay, if I have a veteran who shows up at their doctor's office and they endorse thoughts of suicide, we're pretty capable at intervening and preventing that veteran's suicide, okay? But we know that not all, in fact, the majority of veterans don't present to the VA. They don't endorse those symptoms to their doctors. And they're out in the world, living their lives, trying to do the best they can. And how do we reach them? And so we realized that we couldn't stick to clinical services alone, right? Those interactions with the mental health clinic at your VA or community hospital were not sufficient. They were necessary, right, for folks at that point of crisis, but not sufficient for averting the crisis in the first place. So as we moved further upstream or further back from the moment of crisis, we also wanted to look at what can we do as a community, right? How do we reach all those other folks? And so the analogy that was drawn was sort of like a bifocal lens here, right? There's things we need to do right now, right in front of us. And then there's things that we need to do in the future to prevent those catastrophic occurrences months, years, decades from now, okay? And so that's really where we're gonna focus today and where the Governor's Challenge really rests. Next slide. So, said another way, community-based interventions plus clinically based interventions lead to a comprehensive public health program. That's what we're trying to accomplish with this at both the state and the federal level. Now, I'm gonna jump on a soapbox for a minute. Can anybody think of other clinical issues where, as a society, we've taken a true sort of comprehensive public health approach? There's lots of good examples, so that's not a trick question.
Sexually transmitted diseases.
Yeah, STIs, absolutely. What else?
Smoking cessation.
Smoking cessation, yep, it's a big one. Probably the biggest one. What else?
Addiction.
Addiction. There was a gentleman in Peter's session that had a hat. I don't know what it said, but it was written out like the DARE language, right? And there's mixed results with DARE. But I remember in elementary school going through the DARE program. That's public health. That's what we're talking about. Preventing an adverse outcome years before it gets to that point of crisis, okay? So that's what we're trying to do with suicide as well. And the problem is that when we start talking about mental health, what do?
Get nervous.
We get nervous,
Shy away from it.
right? We treat it as something different, okay? Top 10 causes of death in the US. Anybody want to take guesses of what they are?
Heart disease.
Heart disease. What else? Sorry,
Cancer.
Cancer, yep.
Motor vehicle.
What's that?
Motor vehicle accident.
Accidents, depending on age groups, yes. Suicide has been in the top 10 for quite a while. With COVID, that brought about a number of respiratory diseases that were all categorized differently and bumped it to number 12. Unfortunately, making its way back. Yeah, but the big ones are cancer, heart disease, complications of diabetes, right? Suicide is in there. We don't talk about cancer and heart disease and diabetes the same way we talk about suicide, right? They all have biological factors, they all have behavioral factors, and they all have social factors. Yet we don't say somebody committed heart disease, right? But we say that with suicide. Why do we say that? Why do we make it a personal choice rather than a condition of their disease? Shiloh?
Moral implication. You didn't choose to get heart disease.
Yeah, I chose to have that steak dinner last night. Actually didn't.
One's passive, one's active. People think if you're actively trying to leave that you're making a selfish choice when it feels like a solution, not a selfish choice.
Yeah, because if you had that steak last night, you're living your life. But if you are having thoughts of suicide, I'm not comfortable with that. That's something you chose to do, right? It's a stigma issue, right? And we need to break down that stigma in order to start talking about these things equivalently, because when we talk about them the same way that we talk about cigarettes or alcohol or sexually transmitted diseases or you name it, we can then address the root causes and we can provide intervention. Yes, sir.
I think one of the issues is also a lot of those diseases are more recognizable than suicide.
Yeah, there's visible symptoms,
No,
right?
as opposed to obviously if you get some type of whatever exam for your heart, they can see, oh yeah, you have this issue. They can see that you have cancer.
Yeah, we talk about that with PTSD a lot, the invisible wounds, right? And suicide is very much the same way. I apologize, I don't know if we should be running a microphone around. No, okay. Yes.
Might that stigma be rooted in religion, since it has been like not allowed to do or commit suicide for centuries?
Yeah. So there may be, again, sort of that moral, spiritual component. Sometimes you can use that to your advantage in intervention. Sometimes it creates, you know, sort of a point of contention for folks. Yeah. Heather.
I would argue that the STIs and alcohol is a similar flavor of stigma to suicide than opposed to like cancer or heart disease, where you might have done something to contribute it with your environmental factors. There's not like a blame factor like there is with STIs, alcohol, or suicide.
Right, right. Okay. 2 rows ahead, and then we'll go to Shiloh.
Suicide is the hardest thing to talk about because it's the one thing that we can all absolutely do. We can't choose to have heart disease, but we can make ourselves have heart disease. We can do things to give ourselves diabetes, but that's a process. Suicide is an instant decision that we can all make. That's why it's hard to discuss or have somebody discuss with us, because then it makes us question our own thought process.
Well said. We'll go to Shiloh, then we'll move on.
I think the difficult part of talking about suicide is we've created an invisible silo that doesn't really exist if you zoom out of the veteran community. It's the #2 leading cause of death for young adults, and it is a growing problem for empty nesters and retirees. So it's kind of a self-imposed thing that we've put around ourselves, when if we just open ourselves up to it, this is affecting a much larger population now, but we choose not to talk about it.
And, you know, we're using suicide as sort of a broad catch-all category here, and I want to recognize that there's a lot of research and support now showing that there's different trajectories, different, you know, forms of suicide, right? The older adult who just got a terminal illness diagnosis is very different than the young adult who is experiencing a loss of, you know, employment or their home life or whatever. Yeah, we tend to bucket those all together. That's more of a nuanced point, and I think one for intervention, which we're not necessarily talking about here, but something to pay attention to. Next slide. Okay, so let's talk about then, how do we build a community-focused public health comprehensive suicide prevention program? Next slide. So the model that was used was really sort of this, you know, diagram of circles that you see here, that there is outreach and education that absolutely has to happen. So if you've gone to a LEARN training through the WDBA or a SAVE training through the Veterans Healthcare Administration, or a QPR training or an ASSIST training on JVLM or whatever it might be, that's that outreach and education. Get folks trained to recognize the risk factors and the signs so that if they encounter something in crisis, they can do something about it, okay? Meaning connect them to additional supports. There was a program called Together with Veterans that was focused on rural areas, right? How do we get connected to veterans, and who's gonna lead the work in very rural areas? And it was about standing up veteran sort of committees within those communities where folks live and reside so that they're doing the work within the community. And then community engagement and partnerships for suicide prevention. Those are the community engagement and partnership coordinators, or CEPCs, that every VA medical center should have on their staff at this point, okay? Around that are the state level interventions, so that's the governor's challenge, that's what we're talking about today. And then around that are the national suicide prevention programs like 988, like the work's being done at the CDC and SAMHSA. Okay, next. So when all those groups got together and decided, okay, what are we gonna focus on? What's sort of the unifying theme? Because we're gonna be sending these out first to cities, it was called the Mayor's Challenge, and then second to states as the Governor's Challenge. What's our left and right sort of boundary here? And they said there's 3 priority areas that we need to focus on. So identifying service members, veterans, and their families, and screening them for suicide risk, right? Because if we don't ask the question, we don't know what those needs are or if there's something. Okay. 2, promote connectedness and improve care transitions. We know that when folks are going through transitions, their suicide risk increases. That transition from military life to veteran life comes with a 3-fold increase in a population that's already 2 times the national average at risk of suicide. It's an incredibly difficult and risky time, and that's where folks fall through the cracks. So we need to actively look at improving those transitions, improving folks' access to care and how we engage them early on. I think Shawn, you mentioned it yesterday, having overlapping redundancies for folks to get engaged in care. And then finally, increasing lethal means safety and safety planning, okay? We're being frank, we're talking about guns, okay? And that's because about 75%, 74.3, of veterans who die by suicide die because of a self-directed firearm injury, okay? So no, we're not talking about restricting access, we're talking about implementing steps to add time and space between an individual and that impulsive thought that they need to end their life. Because we know that that decision happens quick. Maybe the suicide thoughts have been going on for years, but the moment between deciding today's the day I'm gonna act on these thoughts and the actual action, for more than 3/4 of people is less than an hour. So if we can pre-plan steps to have them think twice, or to make it inconvenient to access that means, or to just stop for a second and think about what happens next, then we've gone a long way preventing that suicide, okay? So those are our 3 groups. That's everything that we're gonna hear about are focused on one of these 3 areas or multiple. Next slide. So this got sent out early on. It started with, as I mentioned, a few cities. They got really positive results from those cities, so they said, okay, we're gonna issue it to every state. Started going out to the states. The US territory said, hey, we wanna do this too. We have large veteran populations within our communities. Can we participate? Yes. So now we have every state and every territory participating in a governor's challenge. And every one of those, because you have unique communities and cultures within those states, decide on their own what that challenge is going to look like. But the common goal is reducing veteran suicide by acting on those 3 priority areas that we talked about. For Washington, we started this back technically in 2020, although planning started in 2019. Governor Inslee signed the first proclamation officially sort of dedicating state effort to this. It was renewed by Governor Ferguson just this past April. And so we are one of, I don't know if this is common across the states, to be one where there's official state-signed proclamation supporting this effort. Okay, next. So as I mentioned, every state, every territory is covered. You can see the timeline here. So the darker the shading, the more recent. I'm proud to say we were in sort of the early wave, so second wave of states, and we've been at this a long time. You'll notice all of our neighbors were kind of hanging out watching it happen. So Washington's kind of killing it a little bit. Okay, next. So what have we accomplished in the first 5 years? What did this actually lead to? Okay, so for priority area 1, identifying suicide risk, that Ask the Question campaign, right? Specifically asking 2 questions. 1, have you served in the military or any branch of the armed forces? Not, are you a veteran or are you not a veteran? But have you ever served? And 2, are you having thoughts of suicide? Okay? And this was targeted specifically at veterans, but also groups like first responders who are maybe engaging with those veterans who are in a crisis and not knowing, hey, I'm dealing with a veteran, they have specific resources available to them. I can refer them out to this program that I'm aware of, where there's these things I should be considering as I approach them to talk about this issue, okay? So resources for those first responders, including a little QR code that they can keep in their other materials that they can scan and says, hey, if you're talking with a veteran, remember X, Y, and Z. Use 988. Use your local VA facility. Ask them about branch of service, get a conversation going, right? We were talking about that earlier, of like, how do you meaningfully engage a veteran? Focus on providers in group 1, right? So ensuring that the provider community, those who are serving veterans, know that they can get free consultation from national experts on suicide, regardless of whether they work for the VA, the state, doesn't matter. As long as they have a patient that they're caring for who's a veteran, they're eligible to get free national consultation. Folks aren't aware of that, right? Consultation on that level is something they usually have to pay a lot of money for. It's offered free. So we want to make sure folks know about that. For group 2, we talked about, or actually worked on implementing the ETS sponsorship program. That's transitioned to something called Onward Ops. Anybody familiar with that program? Okay. Onward Ops is essentially a sponsorship program where a veteran who's separating and coming back to their local community, doesn't matter where they're separating from, it could be Germany, it could be Florida, but if they are coming to Washington State, they are going to get, one, connected with a community agency for resources to ensure that some of those risk factors are discussed ahead of time, and ideally paired with a veteran sponsor, somebody who's made that transition successfully, to connect with them, to sit down when they arrive, and say, hey, what questions do you have? How can I help? What do you want to know about the community that you're moving to? The housing situation, where your kids are going to go to school. Let's talk through all those things so that you're coming in with a warm transition to the area rather than trying to figure everything out from scratch. Okay. There's a couple of community agencies that are called Community Integration Coordinators, right? CICs. NineLine is one. Washington State Department of Veterans Affairs is another. So those are the folks that are receiving those individuals and helping them settle. Okay? Create sustainable partnerships for veteran-focused nonprofits. That's a fancy way of saying we want to work together. We can't keep doing siloed work. We have to partner. Because if a veteran shows up in Skagit County at Chris's door, and he said, hey, I need to make this thing happen, we don't want Chris to have to try and just start over figuring out how to do that. We want Chris to say, hey, I know a guy, let me call him, we'll do the best we can to try and make this happen and make it as easy on you as possible. If there's nothing else we can accomplish through that, if we can make that happen, I will be happy. Okay. Credential healthcare providers is veteran ready. So anybody heard of Psych Armor? So it's an online sort of education resource library. Really good production value of the training materials. They're free to make an account with, and you can access pretty much all of their courses. They have a veteran ready certification, right? A set of 15 courses that if you as an agency can attest to completing 60% of the courses in that 15 or 60% of your staff complete 60% of the courses in that training program, then you can get a 2-year certification as veteran ready. Meaning kind of like, if you remember the Safe Place stickers on the outside of grocery stores back in the 80s, it's kind of like that. You can put something up on your website, your storefront, whatever it might be, that says, hey, we're veteran ready. So if a veteran walks in the door, we've been trained, we know what their needs are, and we're going to help them out. Okay. We piloted that with the Providence Medical Centers here in Washington State, as well as a number of community agencies. That started around the same time as COVID, and folks were kind of going through that Zoom fatigue, and then they're asked to do more online training. It was difficult for them. No one reached that threshold of the 60% that I mentioned. But we showed that there were folks very interested in those trainings and able to complete those courses pretty effectively. And then providing VSOs. Any VSOs in the room? Veteran Service Officers? Okay. Providing VSOs with free, high quality gatekeeper training for suicide prevention, right? So that was through the Veterans Training Support Center and the local VAs to provide that training to reach out and say, hey, you're gonna encounter folks that are in crisis. We want you to be prepared as possible to deal with that. You shouldn't have to go seek that training because something happened. We wanna train you ahead of time to make sure that you're ready. And then for lethal means safety and safety planning, providing comprehensive lethal means safety training, promoting safe storage options. You saw in the video, gun safes, those were distributed. We partnered with Children's Hospital as part of their violence prevention program. They were focused on accident prevention, right? And we came in and said, hey, what about suicide? Can we get gun locks and locking devices for that reason too? And they were like, absolutely. So kind of an unprecedented partnership between King County, the Seattle Children's Hospital, the local VAs to work towards a combined effort there. So a lot of really promising stuff, but the Governor's Challenge had kind of a 5-year lifespan. We're at the point where that's wrapped up. And so we're thinking, hey, we still want to keep doing this. The work is still needed. We need to keep these partnerships going. We need to talk about joint action. So how do we move forward to the next 5 years? And then the 5 years beyond that. Next slide, please. So to talk about those next steps, we're going to hand it over to Nicole, but I'm going to point to Elizabeth because this is your favorite picture.
Tough act to follow after Dr. Pruitt, and then also not being nervous at all that Shawn's mentor, who's my current supervisor, is in the room as well. So the current efforts and group report outs. This is just going to be an overview, of course, from the people directly that were involved in all 3 priority groups. And what we've done, what some of the efforts are going to be, and then we're going to move into reviewing, moving forward, what we hope and what we're hoping to gain from you all. Can anybody tell me what is one of the common words before we move on that has been used in almost every one of these slides?
Partnership.
Correct. And then what else? Another one.
Hope. Hope.
Hope, yeah. And community, right? Community base, community involvement, community advocacy, etc. So community should be the forefront moving forward into something to like kind of lock in, because the community is important in all the work that we do. Each one of you in this room contributes to, even if you may not even know it or not, it contributes to the Governor's Challenge. It may not be very profound or visible or even part of this report is really cool video, but what you each do each day matters to what our goal is and what our mission is. And so with that, we will start with Ms. Emmet, who will speak about the priority group 1. And just real quick, that picture, you don't have to go back, that picture was actually taken this May, and this is not representative of every single person that was part of the Governor's Challenge. And of course, they put the newbie next to the governor, so I get props for that. But this is just a small representative sample of everyone that had been part of the Governor's Challenge up to this point, where in May, Governor Ferguson signed the proclamation recommitting Washington State to it's the Governor's Challenge and the Mayor's Challenge, because we have some mayors that are involved in that with cities. And so, really cool group of people that got to be a part of that day. And I'll hand it over to Elizabeth.
We laugh because I started somewhere on the far right, and I just kept getting pushed and pushed and pushed. And my kids say I look like a floating head. And so for my birthday, they cut out from the Haunted Mansion, Lenora, which is the lady in the magic glass, and they put a picture of my head in there. So there we go. It's terrible. Anyway, so next slide, please. So I was in work group 1 with a bunch of fabulous people. Will is here, he was in work group 1. Shiloh, were you in work group 1 too? Or we just sat beside each other?
3 the whole time, we were friends.
So we worked really hard on what work group 1 would look like, and that was identifying service members, veterans, and their families. And then how would we screen for suicide risk? Next slide. And what we thought was important Because not always are they gonna be at the VA. So my example is my husband served for, I have to add it all up, 14 years, 9 years active and then the rest reserve. And he often will be like, I'm not a veteran, I didn't retire, I was never in a war. My kids used to scream at school. They'd be like, anybody in the service, stand up. And he would never stand up, and they would just scream, stand up, stand up. And finally, he started to stand up. I'm like, you served a long time. Why don't you stand up? Again, I didn't retire. Why would I stand up? I'm like, you were around when I was raising kids. Stand up, right? Stand up. I was alone. So we talked about what it would look like, and we decided to focus on Native tribes, educational organizations like schools, colleges, trade populations, community engagement organizations, and first responders. And so how can we get that information out so that when those organizations we might be dealing with veteran communities or members, hello, spouses, children of veterans or active military. Next slide. And what we came up with, this is our little slogan, WISER. Washington's identify, this is a mouthful, so just remember WISER. Washington's identify, screen, refer. So that's kind of like the acronym, so how we can move forward in helping identify a veteran, a service member. And we came up with pamphlets that these folks who are going to help veterans get the resources and services they need, they could look at these pamphlets that were individualized for those areas and look at them and be like, okay, how can I help this veteran member? How can I help a family member? And we could look at it really quickly, be able to identify, and then get those resources to them. We also have cards up here if folks would like them as they leave. You can scan the QR code. Pass it out. So, remember Washington, identifying service members, veterans, and their family, screen for suicide risks, refer for resources. Next slide. So each pamphlet, we had session after session trying to think about what would be the thing as a veteran, as a service member, as a family member, what would you want, what would make you feel welcome? What would make you, if you walked into somewhere and needed a resource, or if someone was coming to you to feel like you could be helped? And as we worked through this, we kind of really brainstormed and we thought, rapport begins at the door. When you walk in, you want to feel like you're welcome, you're not judged. Whatever you say, they're going to be like, thank you for your service. You are, whoever you are, coming in here, you're welcome. So fostering a friendly environment for the service and their family member. That was really important. So when someone picks up this reference, they're going to see that. The first thing it says in the pamphlet. Make sure that you are inclusive to that family member. You're inclusive to that veteran. You're inclusive to that service member. Asking if the visitor or family member has ever served. Again, my husband's the example. He would not tell you he's a veteran, but if someone asked him, hey, did you serve in the military? He would say yes. But if someone had said, are you a veteran? Who was I talking to? Will. When my husband finally were like, dude, you need to apply for benefits. You can't hear, you were airborne, you limp, you're 60, hello? He called, you've never served in the Marine Corps. They literally cannot find his information. I'm like, here's his DD, 14, whatever. Here's my 14 years of never having a husband. Literally, you didn't serve. Okay, so have you ever served? So we also remind folks in these pamphlets that there's 3 categories: active duty, reserve and National Guard, veterans, and retirees. So making people who may not be familiar, because remember, not everybody has served. People may not be familiar for what it means to be part of the military machine. So, getting them familiar with these terms was really important to us. And how can we make the general population familiar with these terms? Because some people, again, don't know. I grew up in Tidewater, Virginia. My whole life was military. Not everybody is familiar with what these terms are. And then at the end of the pamphlets, we want everybody who's picking these pamphlets up, they're going to be able to provide resources, tools, and then there's FAQs for the organizations that can help these providers, FAQs for them, so they know what organizations they can provide help to the veterans or service members. Next slide. This is a lot of information that the WISER contains. I'm not going to go through it all. If you scan that QR code on those cards, the key takeaways as we work through what WISER was going to be, what does it look like? Number one, it's a toolkit that's going to help everybody understand it. The second one is military cultural competency. Larry talked about psych armor. Everybody was burned out from Zoom. I think people are getting back in. I know I have 20 Zoom meetings a week, so I think I'm hoping that's going to start picking up again. It's a really great training course. I think that we'll start to see it better. And it's asynchronous, that's helpful. You can also sign up for training through WDBA. Third is suicide prevention. Learn training. There's this Columbia, I call it the CSSR scale, or you can do the calm safety. It's 2 hours. All of those trainings are available. So there's 3 ways to go through it. If you haven't done it, it's a great program. All of those are options through this training module. A couple hours, you can work through it if you haven't done it. I think I have one more slide. There we go. This made up some of our members. Again, we had a great time. I can't remember, we were group 1, we were pretty serious. I don't know, one of them was a pretty happy group. They were axe throwing, they met a couple times. That wasn't my group. My group was the nerdy group, working on the pamphlets. Next slide. Are you group 2? Were you the axe throwing group?
No, not that cool. I mean,
I was a nerd.
I know. The whole time I'm thinking here going, Elizabeth's gonna give me grief, and then next thing I know, she knows my wife, so anything I say, she's gonna go and tell her and say, Stephanie, you'll never guess.
I am gonna tell her.
I know. I appreciate you for that.
Thank you, everybody.
Good afternoon, everybody. This is such a complicated, convoluted, beautiful initiative. And there I was, right? That's how I'm gonna start this. There I was. Imagine 2019, I have this young, inspirational young lady come to my office and she goes, I just started working for Peter. I want you to come help us. We're gonna start this group and it's gonna change some lives. Okay, what's your name? Right? Cody Garza. Right, so Cody came up to me and said, hey, Peter and Alfie and Mary and Larry and all these people want to do this, and we're going to redefine mental health, and we're going to do these things, we're going to build positive communication. Great, COVID. Peter retired. Alfie retired. Cody's husband got transitioned. Surprise, Larry and Shawn, good luck. But we're still here, and so is Peter, so life is good. But it really has been a journey, right? And learning the connectedness, or as it says here, promoting the connectedness and improving the care transition was always that goal. Identifying the community partners, really understanding what the needs of our counties were, our veterans, our unique needs of our VSOs, of our partners. I mean, Chris and I just had this discussion. It's really been an interesting couple of years, and again, I come back to, imagine during COVID, you now have to build all this work out. You have to find a way to build up all these initiatives, communicate with external stakeholders, and by the way, you can't meet in person. And you have to attend virtual trainings for 3 days, 4 days, and rinse and repeat, and figure out how you're gonna build up all the components to this. So that was the challenge we faced. So to say the least, as I'm sure all of you can appreciate right now, it was a bit of a challenge. Next slide, please. So, the goals that came out of this, really enhancing awareness of the resources, services, and benefits available to our service members, veterans, and their families. What does that mean, right? It's about meeting people where they're at. It's about identifying what those resources are, the tangible, direct services that can help with the situation that you're facing. That was really the first pole of this. Marrying that with the increased access to resources, services, and benefits available to SMVF, and boosting the coverage and utilization of the resources, services, and benefits available to the SMVF. Okay, how do you track that? How do you get that information out? How do you build a network when, as most of you are very familiar with, a lot of us are siloed? We have our own organizations, we have our own funding, we have our own barriers, we have our own marginalized populations, we have difference in religions, moral injury, all the things that comprise our beautiful veteran network, military spouses. Okay, Peter, what do we do? Well, Shawn, let's figure it out. Sounds good, sir. Next slide real quick. This is gonna get fun, I promise. So, when we talk about these pieces, it's about understanding the whole life cycle of the veteran and their family, right? Historically, we've really only looked at the composition of the military veteran, the service member, not looking at the interesting dynamics to Elizabeth's point earlier. Why didn't you stand up, right? We forget and all too often don't incorporate that whole social environment aspect of it. So before the transition from the military is where NineLine really came into play, and where the composition with WDVA allowing us to partner with them, and then signing the very first of its kind MOU, both nationally and locally, with the U.S. Department of Veteran Affairs. I pulled my notes up because I forgot the acronym, so bear with me, please. But for the VSI, which was housed with Larry's team, Aaron Cooper, and then the VSPN, or the Veteran Sponsorship Partnership Network, which under the VHA, National Center for Healthcare Advancement, said, you want to build out best practices and how to communicate, articulate, and connect? Let's do it, we're in. But if it doesn't work, it's on you. If it doesn't work, VA Puget Sound takes a hit. If it doesn't work, WDVA takes a hit. Are you sure you guys want to take this on? Yeah, why not? We've done crazier things. Got the scars to prove it. So that's really where that composition came in. And then also looking at the external tools, i.e. enter Dr. Joe Geraci. We found tools that would help not only coordinate the transition points for our veterans, but also would allow them to come into a system before they ever left service. 90 days. 90 days is that dreaded period, if I'm not wrong, Dr. Pruitt. 90 days before they get out, we all have that same question. And as a combat veteran myself, man, do I wish this existed when I got out. Not everyone had the, not everyone had the resources I did. Not everyone had the random Alfie Alvarado show up to their school and say, you're gonna come work for me. Oh, okay, man, what is it? No, just show me up with some money. I got you, don't worry. Cool. That's where ETS sponsorship came in, now known as Onward Ops. It allowed us to meet the veteran where they were. The goal was to create a comprehensive network, as Larry said earlier, the CICs, using this platform, both for NineLine and WDVA, because we signed up at the time. Never a logistical issue, by the way. 2 agencies covering the entire state, what could possibly go wrong? Right. See all the state employees laughing. So, fast forward, it was a mandate that as individuals were going through SFL TAP, that they would be incorporated into the system, and they would be assigned a CIC in their local neighborhood. So 90% of those individuals start coming through the system to NineLine and WDVA and getting assigned sponsors, as Larry spoke to earlier, and then being connected in the community with those individuals who were veteran ready, pardon the air quotes. So during this transition process, what we learned was we could not do it alone. So then we started reaching out to our county counterparts, Pierce, King, Snohomish, Island, Whatcom, and talking to them about becoming sponsors, better identifying the resources in their neighborhoods, becoming part of this system so that veterans, 90 days before they ever step foot out of the gate, are connected with someone who's been through the same life experiences. A peer, if you will, someone who can help navigate them, support them, and identify the barriers that they themselves are falling into. It also allowed for a variety of individuals with different backgrounds, different lived experience, and supported them on this terrifying journey. I mean, I know for me, that was scary as hell. Single dad, straight out of the Army. As a punk kid, all of a sudden thrown into this brand new world. I wasn't even told how to dress, act, walk, talk, eat, nothing. But for the last 4.5 years, I've been told how to do all those things. Oh boy, here comes the culture shock, Shawn. Again, I was blessed. Not everybody had the Alfa Romeo, the Peter Schmidt, the Heidi Audet, the Gary Lott. Not everybody had those pieces. So when this came up, we said, well, okay, let's get rolling, let's keep going. And during that transition period, these individuals, these support elements, were connecting the veterans to their desired outcomes. Oh, you need employment, and yeah, let's talk about your experience, let's talk about what we can do. Hey, you know, we got Seth over at ESD. I'm just picking on Seth because I know him. But we got Seth over at ESD, he can connect you with work. He can connect you with resume support. We got Shadow over at NineLine. He can get you into resources. Why not? So it allowed us to take a step forward in a different direction. We were using peer-centered, evidence-based practices, let's focus on that word for a minute, evidence-based practices to support the veteran. In turn, making it to where the family member also knew what services were available, connecting them to their state VA, connecting them to their services. And for a lot of providers in here, correct me if I'm wrong, but the following sentence is probably coming out of one of your clients' mouth. I'm a veteran. I get benefits. I can file a claim. Where are my VSOs at? Just really quick, I'm just curious. Chris is on his phone. It's always Chris Diaz.
Working hard here.
I know, buddy, I'm sorry. But it was connecting them with those resources. That was the big takeaway. That was the win for us. We had a system. We had VA national support. We had our Maverick. I know we used that from the joke yesterday, but we had Dr. Pruitt. We had Cody Garza. We had the support of the WDVA, and the nonprofit sector's up to bat, and the private sector's coming in, and everyone's really pulling their weight. I mean, you guys saw the picture of the Seattle Seahawks. Task Force 12, we pulled the initiatives, we got the things. Heather Sanchez with her initiatives. It was really bringing that network together and putting emphasis on that peer-to-peer evidence-based relationships. The non-clinical meets the clinical. We now know, so who do we refer them to? Next slide. Okay. Fun times. All these beautiful people up here have been paramount in this. The connectivity, the understanding, the building and developing, and taking their different regions of their services, coordinating together to build out a larger plan, a larger impact, and helping them understand it doesn't matter what sector of service we're coming from. We have the resources. In fact, most of you in here are those resources, right? We have the connectivity, the communication. How do we break down those barriers? How do we sell this to people? How do we get them to get involved? Real simple. You guys all have a passion to serve. As Peter earlier, you know, we talk about what our backgrounds are, we talk about what motivates us, what gets us involved. Everyone in this room has a passion to serve, whether it's through a family member, whether it's through direct service, that's what brought us all together. So, to my surprise, during COVID, after we went through all this crazy training, and after all these Zoom meetings and conversations and everything, I was like, how are we going to sell this to people? We just start emailing people. We start calling them. And to our surprise, we're like, yeah, let's get involved. I'm not gonna throw anybody under the bus, but I had to tell a couple of WDVA employees that working past 8 hours a day was not okay. I appreciate you guys' passion, but, you know, so that's really what it came down to, is how do we continue to coordinate? And so as this has organically evolved over all these years, what we start to see is a shift in how we coordinate as partners. And the emphasis on the Governor's Challenge, no matter what way you look at it, Group 1, Group 2, Group 3, has really been the connectivity. This is a statewide initiative. And in case you guys haven't heard recently, Washington State really leads the way in that. Those clinical, non-clinical, peer level, peer-centered, client-facing, evidence-based practices. I can say that all day. Kind of gives me chills, actually. Next slide. And I think I'm done.
Guys, I was curious if you've had any experience when you get that many people in a group together and they all want to contribute, they may think their method is the best. So have you had experience where people come in and they think their contribution is the most important? I'm trying to put into words like the competitive nature that can come from a bunch of people coming together. And then setting
Did you
aside.
say veterans are competitive? It's unheard of. I'll want to compete. Yeah. Well, we were actually just talking about this earlier. Larry and I get a little competitive sometimes. The answer is yes, but it's organic. It's human nature, right? It's not all bad. Competitiveness keeps us going, keeps us the blood pumping. How do we get more people involved? How do we motivate and incentivize people to want to volunteer and support, using their time, their energy, their efforts?
So focus on what you're going to provide, not the people in the group.
And that's it. Because people have shared goals. And in the case of what we were doing with Group 2, we wanted people to be motivated to communicate, be part of the healing process for people who are about to face the same things that we may have faced 5, 10, 15, 20 years ago. Because it wasn't age specific, it wasn't era specific. If we have Vietnam veterans who are sponsors, they can support a Vietnam veteran. An Iraq War veteran, self-serving at this point, right? But as a combat veteran myself, now I have the ability, I've gone through my growth process, I've had amazing leadership and support. I can now promote post-traumatic growth. I can now support someone's goals. Meanwhile, motivating the people around me to want to help others as well. It's advantageous, right? What's good for the geese is good for the gander. All of us have gone through some transition in life. You can call it, whether that's the military, veterans, healthcare, basic needs, childbirth. The list doesn't end anywhere. So how do we prompt that? You're helping others. And that was the shared goal. It's not selfish, it's how do we get to the end goal? And by being competitive in that, and trust me, we are. I'm not making eye contact with Larry right now because it's too much fun. But it's good competition. The goal is to improve each other and work off our strengths so we can build a statewide push to benefit our military, our veterans, and their families. And if we can hit them, to Larry's point from earlier, 30, 60, 90 days before we get out, we have that early prevention, and then the 90 days following, we have that productive post-vention, if that helps answer your question.
Oh, thank you, Shawn. Yeah.
My pleasure, Shawn. I didn't pay him to ask that, by the way. It's just, I heard Peter was handing out checks earlier, I was like, any other questions for me? Cool, thanks guys.
Awesome. So the next party group that we're going to review.
They got to throw axes.
Yeah, except that I didn't get the invite, and I was right when I was going out. I was like, hey, this is a fun group, and I've been part of the nerdy group all this time. No, it's a great group. So the priority group 3 focuses on increasing lethal means safety and safety planning. Next slide, please. So service members, veterans, and families tend to have, of course, as Dr. Pruitt and Larry mentioned earlier, is that veterans have more access to firearms, and deaths by suicide are typically depending on the data from whether it's federal VA or Department of Health, from CDC, it varies between 73 to 75%. so you maybe average about a 74% firearm, which is causing the most deaths. So with that though, lethal means is not just access to firearms. And as the clinicians know when we're safety planning, what do we look for besides firearms? What do we ask about?
Medication.
Correct. Good job, Shiloh. You were on top of it because you're part of group 3. The other thing that we also secure is sharps, right? Is that we ask about, do you have access to sharps? Do you have access to firearms? Anything that could be potentially dangerous, medications. Because in addition to serving veterans, we also serve family members. So let's include them as well. So even though we're talking about death by suicide, we're locking up medications, we're locking up firearms to also protect family members, right? Children that might get into firearms or medications. Department of Health, who has been fabulous at giving us data as our partner, shared that about 178 deaths in 2024 were due to drug overdose, synthetic opioids, and psychostimulants, so your methamphetamines, Adderall, Vreeland, etc. The great thing about this effort, though, is that over 3,300 locking devices were shared among the community. That include the cable locks, trigger locks, lock boxes for securing firearms, and then the medications. So good job to group 3. Not only did we have fun, you did some really cool stuff. So at least 3,300 households had secure firearms, medications. For the children, it's locking up that TV remote or a cell phone that goes into the lockbox. Next slide, please. So the goals is expanding the number of trained interventionalists. So your gatekeeper training, such as your Learn that we provide here at WDVA, would be the SAVE through the VA. It's teaching the gatekeepers, the people that are touching the lives, the direct crisis responders, that peer in the community, that VSO person that is there and a veteran walks in your door, right? It's teaching them how to ask the question. Hey, I noticed that you seem distressed. What's going on? So it's providing that training to the average community member, that it touches the lives of service members, of the veterans, of the family members. It's mitigating the stigmas associated with gun ownership. Depending on what county you're in, depending on what part of the state you're in, you may or may not be able to talk about firearms. That's not a thing. Among the veteran community, you mentioned the word lock, secure firearms, or law enforcement, and it's immediately, absolutely not. Let's not talk about it. But we do need to talk about it in some ways. Not that we're discouraging the, owning firearms. It's about securing it and making sure that it's responsible gun ownership. It's increasing the distribution of firearms and medications. So things like the lock boxes, rifle cases, trigger locks, the cable locks. All these things contribute to the safe storage of firearms. And then of course medications as well. Department of Health, Elizabeth's group, did the pouches that have the combo on them, where you can stick medications in them. There's safe return of medications at different pharmacies, the mail-in, for example. But again, it's to reduce the amount of dangerous items that could potentially be unsafe to individuals. It's enhancing the education and awareness of gun shops and and then the range staff that regarding service members, veterans, and their families to help mitigate. Again, it's to help prevent suicide. And then enhancing our outreach efforts. So many of our groups in here, we do a lot of outreach. You'll see us at events where John mentioned we provide resources. Larry's team as well provides resources. We all are sharing information, and it's making sure that the community has the awareness and the means to be able to hey, hey service member, hey family member, hey veteran, here's some things that we can do to help keep you safe. Next slide. And then for group 3, again, the fun, AKA fun group, included many of the members, and each person contributes to it. So what Shiloh said is that we all have a shared goal, right? We all work towards the same thing, towards the same goal, just in different ways. And it's about collaborating, and it goes back to that word community and partnership. So this is our fabulous folks. Not everyone could be here. Big shout out to, I want to give a shout out to Safer Homes. Brett Bass was phenomenal in contributing to this group. That program is no longer in existence, but thought I would bring a shout out to him because he did a lot of fantastic work for us. All right, next slide, please. All right, so vision for the future. Any ideas? So now everyone's shy. No, go ahead.
So something that I had in peer groups as a veteran and as somebody who
was also in the WTU process as somebody who's combat wounded, the one thing that we all saw lacking was opportunities to share our story of working through this thoughts of suicide. Because if we ever, the question is, have you ever had thoughts of suicide? If you said yes, it automatically went to this whole other realm where you wanted to say, yes, but this was my positive outcome working through it, this is what I used. Very rarely do you get the opportunity seen in a really positive light to say how you worked through it. Again, when we talked about the other things like the alcoholism, the working through cancer and things, there's all kinds of things to say, I am a survivor of because of this. And there are things where you see survivors of attempted suicide, and it's very sad, and it can be very obvious things, but very rarely do you see the unseen, obvious survivors of suicide. So I think that too, instead of being a kind of a hidden peer group, should really get a spotlight, because there are so many people who have had those thoughts, either as teenagers or as veterans, who work through it really positively. The other thing is people who have had negative experiences. Like that's something too, when you're at the VA or you're going through your exit process, you're never asked, have you had a negative experience in your medical care that you feel will prevent you from going to seek care later? That in itself, if that can be found out and just a little, like a pin in that, to say that that could also be an identifier of a future suicide, because that person, depending on the severity of that negative care, could be a huge identifier to potential future for self-harm.
Agreed. I like all the things that you touched upon, and if you can hit the next slide, we can kind of go in and then add additional stuff.
Can I just say one thing?
Yep.
Really good point around the other folks that are impacted by those behavior. Used to be, we talk about, oh, for every suicide death, there's 6 folks impacted, or 9, or 12. Gross underestimation, right? The most recent research shows us upwards of 135 other folks that are impacted in measurable ways. So not just they were sad at night, right? But they had measurable changes in their own levels of depression, anxiety, and suicidal ideation, right? So the goal here is, yes, we want to intervene, we want to prevent suicide, but we also want to look at how do we mitigate suicide risk in the community, because we know it's much bigger, right? There are roughly 50,000 suicide deaths in the US last year. Just multiply that by 135, remember we're talking millions of people, millions.
And to your point though, is addressing a lot of the things that we had just brushed upon, right? Is the screening part. Is if somebody says, you show up to your doctor's appointment and they say, or even the emergency department, right? You're going for a stuffy nose. They usually always ask you, have you had any thoughts about harming yourself? And you're like, this is a trick question. Because it leads into the stigma, right? If you say yes, even though it happened maybe 3 months ago, and you say yes, it's right, one tick. On to the next one, the next question. And then they can keep asking, and that's a Columbia screening scale, right? It's that screening. But then also the stigma that comes and the potential consequences, which ties into the stigma of, if I say yes, what will happen? Will my firearms potentially get taken? Or am I gonna lose my job? Is this gonna change the entire trajectory of my career?
And you may have had a positive result from working through that.
Correct. And then the importance of peer support, right? Is the importance of somebody just being able to say, I hear you, tell me about that. What can I do to support you? Versus, oh my gosh, I asked you this question, if you're suicidal, you said yes. What do I do? You freak out, right? Well, it depends on the person, depending on the situation. But that, again, ties into some of the things that we're trying to promote here, right? Is the safe storage and all these interventions, these preventative measures and interventions to help support veterans. And, you know, it does affect other people, because if somebody, let's say, says, yes, I am suicidal, and no, I don't want to go to treatment, their firearms are taken away, they're, you know, involuntary detainment, for example, that's the worst, you know, thing that could potentially happen, right, but necessary for safety. They're a first responder, they're a police officer. We just created an issue there for that individual's career, right? And so that's why it creates that, do I be honest? Or do I kind of work around it and answer it correctly, and then we miss those things? And then, because if you think the job is affected, so is the family. Now there's limited resources. But again, it's not to mitigate. It's not to say don't tell the truth, or that is going to happen, or this is the extreme. It's about supporting, it's like preventative measures to help people be safe, to help support people to where they, if they are suicidal or having thoughts about it, that they come to a trusted source. And then we work through it, whether it's 988, whether it's a therapist, whether it's a friend, another peer in the community. It's important to do that.
Oh, where are you going next?
Yeah, actually, we had a question back here.
Yeah, for the vision of the future, for one, my name is Stephen Nix. I'm a DBOP that works out of WorkSource. Also, I come from a background of a mental health case manager for Blue Diagnosis Treatment Center, and worked in corrections and was trained under SPLs, so I know the suicide prevention levels and everything else. I see some flaws because I understand you're focusing on veterans, but you're not focusing on the negative factors in the community acceptance of the veterans. Meaning, how are they feeling this? Why are they? What activities are happening? What resources do they have from being ostracized from the communities or retaliated? Because with military family, you have multiple MOSs. For me, being a combat veteran, basically combat infantryman, Iraq, not everybody did the same job I did. A lot of them stayed on basically inside the wire. So when they came back, their experiences were different. Or they were stationed over in Italy on the Air Force Base. But every single one is automatically ostracized, saying, you have PTSD, I'm afraid of you because you're military. Then we get discriminated on promotions, even with the state. We hear a lot of thank yous, but those thank yous are not, they're vacant of emotion and empathy. And I definitely want to say thank you for your outreach, but you know, some partnerships I see is like, I don't see a partnership with like WorkSource for one, because everyone that comes through our doors is in crisis because they lost a job, everything they do is not working. They can't provide for their families, they can't provide for anything. And they get the same thing. Well, thank you for your application. Though you identified yourself and you have a point system, but we have no point system, so you're not gonna get selected for the next round. That's what they see. So there's a lot of flaws, and I see that you're focusing on the veteran, but you're not focusing on the negative stimuli that needs to be focused. Like when I came back from Iraq, I'll definitely tell you what happened. Fallen comrades were having protests of basically why we shouldn't be in Iraq at their funeral sites. You had banners everywhere, and it's like, oh, we support our vets. There's continuously everything out there that says, no, you don't. So instead of like focusing on the veterans, you need to re-educate the population of acceptance and show them what, basically certain rhetoric needs to be punished, or they should be held accountable. Because if you truly support the vets, they're not, a lot of vets, I'm sorry for changing this, but a lot of vets receive PTSD from their reintegration into the communities of their choice.
Thank you for sharing that, and you're absolutely right. We should be looking more at the person and what resources in the community that we can connect with too. It's not just here and what, and And so if we go to the next slide, I wanna address some of the stuff you said, because I would at least like to go towards a little bit about what both of you have said thus far, right? Is a person-centered approach, because some people have great experiences, some people do not. Some people, like you said, some of these, the acceptance from the public or understanding comes with a stigma. PTSD, that guy's probably off his rocker. And so there's a lot of this perception in the community. You can say to one veteran, thank you so much for your service, I appreciate you. You say that same exact thing to another veteran and they're like, you're thanking me for doing my job, you're thanking me for harming people? Yeah. Here's where to go. Don't thank me, and then it becomes, so with that, it's trying to do a more holistic approach, is treating each part of that, right? Each person's different. Every veteran is different. Every service member is different. Every family is different. And so with that is trying to take that person-centered approach. We're never going to be able to meet 100% of every single service member, every single veteran's needs, wants, and all that good stuff. But we can try, right? I mean, I know that, sir, that may not answer your question or make it feel any better, but we're trying to move forward, and that's where you all come in as a community, right? Is how do you contribute to what we're trying to accomplish? Person-centered approach is looking at veterans holistically as the whole entire person. Not just one part, not, okay, you own firearms, okay, this is you. And this, you have PTSD, that's you, and whatever. It's the whole person. It's the whole person. And then veterans are people. Somebody told me the other day, we all put on our pants the same way. And I was like, well, I don't know. I could challenge that maybe. But it's trying to take a look at treating veterans as people, service members as people, because that's what they are first and foremost, without minimizing an experience, without minimizing that person's service, but also trying to connect to people as people.
So outside of work, I work with men for the last 6 or 8 months. If you ever run into a point where you're trying to get past the weapon safety issue and they feel like their guns are being controlled, instead of fighting it, talk to them and listen to them and find out why they don't want their guns locked up, find out why they think they're being controlled. Because what I found is I'm not able to get guys to lock up their firearms for themselves, but I can usually get them to do it for their kids or for their spouse. I can think of one veteran, he kept his firearm loaded on the top shelf in his closet, and he said, I know where it is and I know it's safe. And I said, well, you have kids, you have 3 of them. Do all 3 of them know where it is, and is it safe if they touch it? So those are things that we can do. We kind of get scared to have those conversations because they're uncomfortable. We don't want to offend people. That's how we get to know people. That's how we serve them better. And I just wanted to say thank you. Most of us could share a story that puts us on the verge of tears, but we're scared to do it. But everybody here has a heart and loves everybody that we serve. So I just wanted to say thank you. And men are stubborn, but talk to them instead of talking through them. Just listen to what they have to say.
And then that comes with, thank you, Shiloh, for that, just kind of that, building that connection. So thank you for mentioning that. It's, again, this is ongoing. So the future, it's ongoing, right? We learn as we go. Things change all the time. But it's also implementing the best practices that are tailored towards service members, veterans, and their families, right? Even though veterans are people, we still have intricacies and nuances about this population that we need to be mindful of, we need to be aware of. There's uniqueness about it. And then also making sure that we have what the barriers are. Like we take the time to figure out what are the barriers, what are the challenges, what is it that we need to be mindful of in order to best help that individual, to help that veteran, to help that family member. Preventative measures. I mean, we're not new to the system, right? Is that a lot of our systems in place, think about, medical care. It's reactive versus preventative. And that's what we're trying to accomplish here. Again, we're not gonna come out perfect. It's not gonna be perfect 100% of the time. But having preventative measures in place, not to end it, but also to prevent somebody from maybe getting to the point of crisis, right? Because that's a scary place to be. It's scary to be vulnerable. And then the community connection. So there's that word community again. Partnerships. That's where you all come in, right? Is that we can do this together. We have a shared goal, shared mission, and we all have different experiences to bring to the table, right? And so it's important that we get everybody's voices. We may not agree. We may not agree on something, but again, as Shawn and Shiloh both mentioned, we have the same goal and we can work together. And then representing the SMVF community on their behalf, and advocating on their behalf. So that means, to me, it's coming without an agenda. I'm not coming as Nicole, the WGBA person that wants to do this because I think this is best. It's taking a look at what are the needs, and I'm advocating without the agenda. I'm coming without necessarily a motive, right? We're all working. The motive should be is we work together to accomplish the goal that we're working towards, and then being flexible to be able to pivot. Hey, we're going and we're doing this cool Wiser thing. Hey, wait, we didn't think about this. We didn't think about maybe we need cultural competency as part of this. Let's add this to the Wiser certification, for example, as part of identification and screening. So it's work in progress. Next slide, please. The why. And this, I think everybody knows what the why is for themselves, which may differ for each of us, but may be common or, commonality. Can you go to the next slide? So just real quick, I know we're kind of short on time and I want to make sure that we have some time for at least some questions. So violent death statistics. So this is from our friends at Department of Health. In 2024, 211 deaths by suicide among veterans community, which again might differ. Their definition might be a little bit different than the federal VA. But Department of Health's definition is any of a veteran, any person who served in the armed forces. So it's not categorized by any specific way or means. Let's see, we talked about the overdoses, and then one death is too many, right? One death is too many, 211. There's an asterisk next to that number. Why? It's because we don't know a lot of these things of how somebody may or may not have passed away. An overdose may or may not have been a suicide attempt, or or actual suicide, I should say. It could have just been a pure accident. So there's an asterisk there because as they gain information, the number may change. And then approximately 73%, as I mentioned, is death by firearms. The highest groups for our veteran community, transitioning service members, Shawn touched upon it. It's usually the deadly gap here, right? First 12 months. Usually the first 90 days, 3 months. Toughest part, because they're trying to reintegrate into civilian world, which can be very hard. You're trying to find employment. You're trying to figure out that, hey, I'm no longer getting DH. How am I going to pay for my rent? How am I going to pay for my mortgage? How am I going to do all these things? How am I going to support my family? And then veterans 55 and older, and then veterans in rural communities. Next slide, please. Who makes up the Governor's Challenge? Again, you're all highly intelligent folks that can read quite well. But we have our federal agencies, we have state agencies, we have community organizations. We have individuals that support marginalized communities and groups, so LGBTQ. We have our Native American tribal, our federally recognized tribes, and just a bunch of different folks in the community. Because why? We are part of it. Each of us are part of the community. Next slide, please. Good. So what can we do? Goes back to partnership and community, right? Is that we are all part of this. In each one of these, you can look. Suicide is a public health crisis. We're all part of the public. Service members, veterans, and their families are part of the community. We are part of the community. And it just trickles down to everything. It doesn't cost much to be an empathetic person, to listen, to be kind, right? Is to try and understand. We may never understand each person's, things that they're going through, but we can be present and just say, what can I do to help? Doesn't cost a whole bunch. And then asking someone if they need help or support. Because you may see somebody sad, and one nice, kind gesture may change the trajectory of how that person goes on with their day. So something to be mindful of. Again, doesn't cost a whole bunch. It might just be a little bit of time. Next slide. All right. I thought this was fun. And so yes, we need you as far as the Governor's Challenge. We are always open to new numbers, new insights, new ideas, new ways of doing things. And that's where you all come in as a community, as our partners, right? It's not just WDBA, it's not just the VA, it's not just NineLine, it's all of us. It's all of us. It's not just the members either on the screen. So something to be mindful of is if you feel that you can, just bring your ideas, be open to being vulnerable and sharing those things, that can open up a lot of different ideas and ways of how we do things to serve veterans and to prevent suicide among our service members, veterans, and our families. So your voice is valuable. it's meaningful, and you might be doing it every single day with the work that you do, but you know, you contribute in different ways. The next slide. And so, help us serve, right? Help us serve those who serve. You know, the Governor's Challenge allows for opportunities to network. It can be valuable input to the work that we do moving forward on behalf of the state and our community, the ability to partner with other agencies, groups, and organizations that share the same goals. And then suicide affects all of us. You know, I think you mentioned it earlier, you know, it may impact one person's life as far as directly the physical part of it. But how many people, their loved ones, their friends, their family, all these people are affected, their community. And it's heartbreaking, right? And so we can serve fellow Washingtonians and our veterans by just being present, by sharing our ideas, giving us our time, asking the questions, educating people, right? Hey, I don't know what you just said, but that's not really true. Kind of what Shiloh said is like, you don't know what you don't know. And that's what we're here to do, is help each other understand. So, you know, we have to seek to understand. And then if you're interested, this is just our suicide prevention team's email for any information. It looks like we have a question.
We have one over here.
And over here, and well, many.
Yes, so just for clarification, the Governor's Challenge, these three facets or programs, is to equip organizations to implement the, like for example, peer support groups within their organizations. The reason I'm asking this is a lot of these initiatives or proposals, and that once they go to the implementation phase, it stays with the organizations. So do you get feedback if, you know, how well is the implementation going in those organizations? So for example, peer support, especially with certified peers and peer groups, there's, for a long time has been had this challenge with hierarchy. So if you're, you know, talking about peer support with a clinical agency, sometimes they carry that stigma related to peer groups. Because, oh, it's not facilitated by a clinical, a clinician. But peer groups work well, especially with this demographic, when it's led by a veteran peer, or, you know, the state trains, you know, as a certified peer. Before I went to social work, I trained as a certified peer. So I guess at least with that, I have great passion to know the power of peer support. But like those organizations that are in there, you know, do you get feedback? Have they implemented those, you know, that program? How well is it doing? Are they reaching the people on the ground? Because sometimes we have these work groups, I guess, but we don't know whether or not after we spread the good news and or the good ideas, whether it's been effective. Because old Joe or Dan that's stuck in his house still doesn't know about that group, or, you know, there's more. Obviously, there's more to it, but it's just so there's a clarifying question, and also there's feedback.
Sure. So I think some of the members that you saw on here, they are contributors. They're part of the group that contributes that. And I don't know, Larry, Shawn, Elizabeth, I think they can probably speak a little bit more to it. But in my experience, the work that we do here at Governor's Challenge, and then even with my own team here at WGVA, it's like being able to, it's planting seeds and then not knowing if you know, there's no necessarily a measurable outcome, right? If I help Shawn and I never see Shawn again, I don't know what happens to Shawn. And that's a lot of our work, right? And so with that, we'd like to hope that preventative measure, just that seed is planted and then it goes elsewhere. As far as feedback, you know, like the Wiser, for example, is a deliverable that we have. You know, as far as the success, I would hope, again, it's one of those unmeasurable things, right? I don't know how many trainees or people who are Wiser certified now contributed to ending, you know, suicide or preventing suicide. But it's always, it's a, you know, kind of a revolving thing, right? It's pivoting when needed and then changing the perspective, and that's where we have to reevaluate quite often. Real quick on the peer thing, you know, it's funny because, you know, Peter's my supervisor, you know, when one of the first things that we talk about is the definition of peer, right? What is peer support? Because, you know, like what you mentioned, the certified peer counselor, that is the HCA model, right, of how to do the counseling, et cetera. So that is that definition of a consumer of a behavioral health, you know, service, or a family member, or somebody who is a consumer of behavioral health, to be able to do that. Whereas peer is just human to human, lived experience, the experience working with the demographic that you're working in. So with that, you know, I didn't really quite answer your question about the success, but, you know, do know that this work does move forward and it does have some effect. It's just not necessarily measurable outcomes.
We're at 2.
Okay.
So we are out of time. Folks need to leave. Please feel free. We'll stick around and come out and talk with us. We'll ask questions. Peter, did you have closing remarks?
No. It'll be reflected in your evaluation.
Sure.
Can I just ask a quick question? Quick question.
Please.
So I heard there's 5 years, right? That 5 years. Is there a plan to bring back all the, when we formed the Governor's Challenge, everybody gathered in the room and we discussed how we can approach and move ahead. Is there going to be maybe another conference, or get all the groups together and reevaluate, and how are we going to move ahead again? I just was almost wondering.
Yeah. Peter's been out of the game for a while. We have had, we do kind of quarterly in-person meetings, and a lot of those school settings happen there. So I believe, you know, we're due for another, but yes, the answer is yes. That there will be in-person meetings. There'll be a chance for folks to set those goals. And that's why we're also asking for folks that are interested to contact us so that we can include you in those conversations.
Thank you.